So, in fact, I just wanted to share one of the recent publications that I had. We were actually in the Asia Pacific group where we were looking at the gaps in heart failure ecosystem in the Asia Pacific region. And of course, when we did this study, we found that the majority of the respondents were from India. This actually, we took a group of cardiologists and physicians from the country, and then majority responded from India. And then the key aspect of the registry was the lack of patient awareness and knowledge of heart failure accounted for about 80%. In fact, I was just talking to Dr. Mohan, what should we should be doing in this context in our state. And of course, more important than that, and that's why I thought I should be talking more on heart failure today, is the poor physician awareness of diagnosis as well as treatment, close to about 72%. And finally, the major diagnosis of heart failure came only through echocardiography. This is not right. Even today, I think it's important to understand that heart failure is a clinical diagnosis where physicians have a very important role. And not only that, this is a disease of many comorbidities, and that's why physicians also need to be actively involved in the management of heart failure and should be knowing more about this. And finally, just like troponin in the management, in the diagnosis of acute coronary syndrome, NT-proBNP as a modality is really coming up, and this is seldom used in our country. And if we start using this, the diagnosis will be much better and we'll be able to do much more for the patient. So why is heart failure important? If you look at the mortality over a period of time, you find that the in-hospital mortality, we have our own statistics from many registries which is conducted in the country. It's close to about 7%. What is in the world literature is about 4 to 6%. And 30 days, the rehospitalization increases. At 1 year, it's about 15 to 30%. 3 years, 30 to 50%. And 50% of the patients or more, they die at the end of 5 years. So this is really worse than some forms of cancer. And that's the challenge that we are facing today. Just for again to go back to the basic understanding of heart failure, today I mentioned that most of the diagnosis done by echocardiography, and we have mainly two varieties. One is the heart failure with the reduced ejection fraction, when you have the LV ejection fraction less than 40%, and if it's more than 50%, we categorize this as a preserved ejection fraction. And of course, a new entity is also coming out, what is known as a heart failure with a normal ejection fraction, which is an EF more than 60. And this actually has a very different therapeutic strategy because none of the conventional agents would work in these patients. And of course, in between is a heart failure with mid-range ejection fraction, which is between 41 and 49%. And this behaves more like a reduced ejection fraction. So once you have a patient with heart failure, you must understand that this journey of heart failure this keeps on becoming worse. Over a period of time, the residual heart failure risk comes in, there's a worsening heart failure, and ultimately they reach a category of advanced heart failure. And the onus is on the physician to really slow down this progress of the disease process. And what do we do there? So I think when we start seeing patients with acute let's say heart failure, I think the most important thing, we talk about guideline-directed medical therapy, which is what I'm going to stress on, which is perhaps the most important thing for the physician. But I think it's also important to understand whether the patient has a reversible cause. For example, somebody has an uncontrolled hypertension, or let's say accelerated hypertension, and they come with a reduced ejection fraction. Just a proper control of hypertension might be the factor which brings him back to normal. But one must tell that the commonest reason in our country, at least 75% of our patients with heart failure have ischemic heart disease. And so it's important from the physician's point of view to work up for an ischemic heart disease. Troponins are absolutely essential. And not only that, if you look at the statistics, even in the United States, you find that the angiogram is done only in about 30% of the cases. So I think there's still a long way to go. We need to really rule out ischemic heart disease. And as I had mentioned, reversible causes like accelerated hypertension, chronic kidney disease need to be attended. And one more important thing is an entity where, an ECG is always abnormal, at least in acute decombinant heart failure. What we have studied in our country from our own registry data, we have seen that 90% of the patients have an abnormal EKG. And if you find a left bundle branch block, these are the category of patients which needs a special attention. I'll come to it a little later on. Thyroid disease, anemia, I said this is a disease of many comorbid conditions, I think it's important for the physician to look into the various aspects like anemia, correction of anemia, and even iron deficiency, which is very important. Now I'll just come to a clinical scenario. This is a patient. This is an elderly lady, actually 60-year-old lady, who was admitted with acute decompensation heart failure. The story was that this lady went to visit her daughter in Canada, had an episode of acute onset breathlessness. She was admitted there, was very sick. Somehow she was detected to have an EF of about 20%. Was treated there, and then she did not want therapy there. Came back, was scheduled to meet me, but then 2 days prior she got admitted with an acute decompensated heart failure. And if you look at the ECG here, this is a classical. This patient had a wide QRS, left bundle branch block configuration. This patient was very sick, was actually stabilized, and then subsequently we did an angiogram, and we found that she had normal coronaries. And so this is the kind of patient that I was talking about. When you have somebody like this was the admitting echocardiography. You can see the very poorly contracting ventricle with an EF of 20%. And then when we found this left bundle branch block, we knew that this was the reason for the heart failure. So this patient was subsequently put onto a device called a cardiac resynchronized therapy, where this is actually a pacemaker with 3 leads, one in the atrium, one in the right ventricle, one in the coronary sinus, which would pace the left ventricle. And after that, we were able to get a very narrow QRS as you see from the ECG. And a little later, this is a repeat echo in the month of February. This is absolutely normal LV function. So I think this is the kind of change that you would see if you are able to diagnose a left bundle branch block pick up a left bundle branch block from the ECG. So I think the first onus on the physician is to rule out a reversible cause, and then we have all these therapies. We have seen that over the years, for example, the ACE inhibitor, the enalapril, was the first drug which was introduced. Subsequently, we saw that beta blockers were an add-on therapy for heart failure. What was a contraindication once for heart failure has become an indication, reduces the relative risk by about 35%. Aldosterone antagonists came. ARNI, of course, the new drug, which I'll elaborate a little later on. And finally, the new kid in the block is the SGLT2 inhibitor, which has further reduced a relative risk reduction of 17%. So much so, today, when we talk about heart failure, we say there are 5 pillars. One is the RAS inhibitors, of which the ARNI is the number 1 drug. Second is a beta blocker, which is again a class A, 1A indication. The mineral receptor antagonists like aldactone or eplerenone, which is the third one. SGLT2 inhibitor, and finally, of course, never forget the loop diuretics. Because people, in the earlier days, we used to say that if you use a higher dosage of diuretics, they have a higher mortality, and the advice is always to reduce the dosage of diuretics. But we know now that when you don't really bring down if you don't have a euvolemic status, these patients get readmitted, and so this is also an important pillar of therapy. Just to illustrate this point, this was a guy who was very sick, and ischemic heart disease, old anterior wall MI, fairly clean coronary arteries, but severe LV dysfunction, heart failure. So this was the echo in 2019. So when this patient was put on all the 4 drugs, and you could see that the LV was poorly contracting at that point of time. Over a period of time, with the drugs, this really made a huge difference. In fact, this patient, once we thought, would even need a transplant, but the drugs really started becoming effective. He had a better quality of life. Now he's in class 3 years later. He became much better. Today, he is now in NYHA class 2. So that's a kind of influence that these drugs today have in our treatment of heart failure. Now, why do you keep talking about guideline-directed therapy? It's very clear from the graph here, whether it's an all-cause hospitalization, whether it's a cardiovascular-related, or an emergency visit. For example, today we also talk about something called an outpatient worsening of symptoms. So all these things are much less if these patients are on these four pillars of heart failure therapy. And not only that, this is actually one of the publications by pioneers in this field, Muthaiya Vaduganathan, who showed that if you have a 54-year-old man, if this person is on all these 4 drugs, you find that the projected survival, he gains another extra 6.3 years of survival if you put in all these 4 drugs. And not only that, in terms of event-free time, if you look at it, it's another 8 years for the same person if these patients are on guideline-directed therapy. So I think just to emphasize the point that once you have heart failure, all the 4 therapies are very important. Now the question is, when do you start this therapy? I think the message should be as early as possible, because you can see the benefits start much early. For example, 14 days, right, for an ACE inhibitor, beta blocker probably by the end of 28 days. MRA, again, there is no point starting an MRA after 28 days. ARNI, 30 days, SGLT2 inhibitor, even, so all these medicines, the significant early benefit seen for each of these drugs. So the message again would be to start this as early as possible. So now the question is, there are some issues to be really looked into. This is what the expert consensus pathway that the ACC looked into, how to initiate, how to implement these patients on the guideline therapy, when do you refer these patients to heart failure specialists, and this is what I am really going to be very concise and trying to share with you. So, though we know that there are 4 classes of drug, I think perhaps the most important drug which would bring down the sudden cardiac death is beta blocker. There is no doubt about it. Apart from that, what has really made a huge change in terms of quality of life, in terms of reduction of hospitalization, is the ARNI, which is actually a combination of sacubitril valsartan drug with the bradykinin inhibitor. So the issue here again is that if you are putting these patients on ARNI as a first line, there was a time when this drug was introduced that we used to actually change these patients from switch over from a ACE inhibitor or an ARB into an ARNI. So there was no patient, none of these patients received an ARNI initially. But now the concept is different. You could start a patient on ARNI as a first line therapy. And again, SGLT inhibitor as a foundation therapy is very important. And the third important message is, you need to start, there was a time when we used to sequence this drug one after the other. Today the recommendation is that you start low dose of all these drugs as early as possible. Now a little bit about the ARNI, because the first trial which showed us the benefit was a paradigm trial where it was compared with enalapril, and there was a 20% relative risk reduction with this drug. And the outcome was, there was a 4.6% absolute risk reduction, and the number needed to treat was 1 in 27. And there was a 20% decrease in sudden cardiac death, which was never seen with any form of therapy. In fact, in heart failure, if you are to prevent a sudden cardiac death in a patient with an ejection fraction less than 35%, people would say that you need a device like a defibrillator. But I must tell you, once this drug was introduced, the need for an SCD has come down remarkably well. In fact, there is a 20% decrease in sudden cardiac death. But of course, people argue that, these drugs are newer agents. In fact, I was very skeptical when this came into the our area. And then we all felt that there was a little bit of hypotension, which is true. It's about 14.7%. But very importantly, if you're very careful about this, there's no worry about the worsening of renal function. Now, why do you keep talking so much about ARNI? Look at this data. If you were to compare this with ACE and ARB, the greater reduction is mortality. What you see in the red graph there is definitely with ARNI. So I think this really is a wonder drug which has changed the way we look at heart failure therapy. We also have evidence, because we look at, as I had mentioned earlier, one of the key things when you look at patients with heart failure is the NT-proBNP, which is like a troponin T. So if you are able to measure the NT-proBNP, now we find that with a hospitalized patient, you start them on ARNI, there is a much more fall in NT-proBNP when you start these patients on ARNI. So that again shows that this is a very useful drug. And I think I am more impressed about this drug because of another feature, which is the improvement in the LV function. No other drug has shown such a remarkable improvement in the LV function like ARNI. On an average, you have about 9.4% improvement in LV ejection fraction over 12 months. And not only that, 25% of these patients had an ejection fraction even more than 13%. So I think this is a drug which has really shown that it can prevent the reverse remodeling and helps you in the improvement of LV function. And not only that, one key thing is that this should be started very early. The moment you have a fibrosis and a scar, for example, you have an ischemic heart disease, it doesn't work that well. If it's a cardiomyopathy, dilated cardiomyopathy where there is not much of a fibrosis, this is a drug which will even work better. I was just mentioning about the efficacy on prevention of sudden cardiac death. We have data from baseline to 12 months. It's probably related to the improvement in the LV function. That is why the requirement for ICD comes down when you put a patient on ARNI. Not only that, it's when you talk about heart failure, we just don't talk about mortality alone, because the quality of life is also very important. These patients get recurrent hospitalization, and ARNI is one drug which has shown a 40% reduction in terms of the hospitalization. There were people who felt that, why don't we, this is a very costly drug. Some patients have themselves been not very compliant. I mean, it may be because some of them have left out for some other reason. And there's a trial which has shown that the THREAD have, if at all these patients are withdrawn from this therapy, the outcome in these patients, they deteriorate. So I think it's also important to understand that this is a lifelong therapy. You need to make this patient understand that it has to be taken very well over a longer period of time. So the ARNI has been really studied in the VALUE trial, where I had shown the improvement of LV function over a period of 12 weeks. Now it is a started therapy which is de novo for de novo heart failure, even in ACE or ARB naive patients. And the low NT-proBNP values which are seen by this pioneer heart share is really very promising. And very important thing is that, in fact, in a country like India, there has been literature even which has been published in the European Society meetings, where patients need not, though we say the target dose is 200 milligram, even on doses like 25 milligram BID, 50 milligram BID, this is found to be very effective in the analysis, in the sub-analysis. So the worry for the physician mostly is, you have so many drugs, you don't have the BP to play with it, which is probably the most important factor. So there are some tips for optimization of ARNI. Initiate when these patients are off IV diuretics. Use a low dose, and if you think that the blood pressure is a major problem, avoid dehydration. Borderline BP, reduce the dosage of diuretics. Titrate to the guideline directed dosage at home, where we have data to suggest that. And direct to ARNI approach, you don't have to start on ACE or ARB. This actually prevents remodeling. The second drug which I wanted to mention is about the beta blocker. Well, today we have data that you can start this at the same time as ARNI. Heart rate lowering improves outcomes. It's got a dose relationship. You must also understand, just like ARNI, the higher the dosage of beta blocker they tolerate in heart failure, they do well. And the small dose initially and then optimization gradually updated over a period of 2 weeks and initiated when the patient is less congested. The only message is that don't start beta blockers when the patient comes to you with pulmonary edema. Give them some time. When they are less congested, it acts better. But no beta blocker if the heart rate is low. The only message is, though there are 2-3 agents which are recommended, metoprolol, bisoprolol, and carbidiol. Carbidiol is better avoided when you have hypotension because this will aggravate hypotension. The third important drug is the MRA. Whether the question is whether before ARNI, it's not used for a diuretic effect. Please don't misunderstand that. It's basically to prevent remodeling. Its efficacy started when it started very early, within 7 days, and not after 28 days. And hyperkalemia is maybe a factor in chronic kidney disease. But today, we have agents which can also counter this hyperkalemia, where patidromere is found to be very useful. The fourth drug, the most important drug which has become the standard practice today, is the SGLT2. I don't want to go too much into data. I think everyone sitting here, most of you are diabetologists as well. The DAPA-HF and EMPEROR reduced has shown us data that this is very helpful in terms of reduction of events. Even in heart failure with preserved ejection fraction, DELIVER and EMPEROR preserved has given exactly the same results. So it doesn't matter what form of heart failure it is. The meta-analysis of all these trials have shown that these are agents which are useful even up to an ejection fraction up to about 60%. So this is a drug to choose. But the question is, when do you start it? There is no doubt that the early initiation of SGLT2 inhibitors is important, irrespective of the LVEF. In fact, Milton Packer says that when you have somebody comes to you with a clinical diagnosed heart failure, just don't look at the echo, just start them on SGLT2 inhibitor. That's a kind of overwhelming data that we have for SGLT2 inhibitor. But then once you start treating heart failure, you realize that this is a continuing process. Maybe there is an acute decompensation initially, as you see there. There isn't, but then over a period of time, once they get discharged, that's a time when you need to optimize the dosage of these drugs. And that's where the role of the physicians really come in. So it's also important to understand that if you want to start therapy for these patients, you better do it when the patient is in the hospital. This is actually I keep quoting this study. This is by Fonor et al., very old data, 2007. What he has shown that if somebody is admitted in the hospital and given a beta blocker, 93% of them, they stick on to this drug. Same thing with ACE inhibitors. Whereas if you start them as an OP treatment, beta blocker, only 30% or 19.6% would adhere to this therapy. What does this tell you? Because patients feel that any therapy which is started in the hospital is very vital for his good health. So they would continue that. In fact, that is an important message which should go down. Start this as early as possible, preferably when they are in the hospital. There are some additional therapies in heart failure like ivabradine when you are not able to control the heart rate despite beta blockade. Your ideal heart rate is somewhere between 60 to 65 to 74. You can add an ivabradine. New drug, this just a passing mention of that about Versiguat. Digoxin, though it does not have any mortality benefit, it helps in reducing the hospitalization. And of course, the PUFA and the potassium binders are also there as the guidelines. So ivabradine, I had mentioned, if the heart rate is more than 70, sorry, it's not moving. Up titration with beta, when the beta blocker is not possible, if there is a contraindication for a beta blocker usage, or and it's not useful if the patient has an atrial pace rhythm, and if there is a paroxysmal AF, never use a ivabradine, because this is ivabradine is one drug which can precipitate a atrial fibrillation. The new drug, which is Versiguat, actually it works on the cyclic GMP pathway. And it has, in addition to the improving the contractility, it acts both on the myocardium as well as on the vascular system. So this has an important effect. So this is produces vasodilatation. It improves the hemodynamics. It has got an anti-inflammatory process. It improves the myocardial dysfunction as well as the vascular dysfunction is also improved. So this is a new drug which has been marketed. And one of the key studies, which is called the Victoria trial, over a period of 10 months, they found that even in patients who have a worsening heart failure, that is, these patients on a conventional guideline-directed therapy, when they are put on these drugs, they do really well. And in fact, this trial was terminated prematurely by about 10 months because of the benefits. In fact, this is one of the patients I had post-CABG. This patient was on diuretics, could not even tolerate even the smallest possible dose of ACE inhibitors. And this patient could not tolerate a beta blocker. The heart rate was so slow. The only drug that I could add in this patient was Versiguat. But then this patient over a period of time made a remarkable improvement. In fact, he came to me for a follow-up yesterday. The good thing about this drug is once the LV function starts improving and the BP picks up, you can start initiating these people on all the guideline-directed medical therapy. See, this patient is doing very well. And despite all these drugs which are available, it's important to understand one of the large registries. This is the CHAMP registry, which is in the US. There you find that the ACE inhibitor is only prescribed in 50%, arginine about 12%. And if you look at that, all the 4 guideline-directed therapy is just 1% of the patients who receive this therapy. In fact, I have one of the principal investigators for the National Heart Failure Registry. When we looked into our data also, we did in 2 parts. We did more than 10,000 patients. Again, it's exactly the same figure. Only about 25% of our patients in India are on guideline-directed therapy. And ARNI is just a dismal 6.69% at this point of time. So there is a long way to go. We have data from other countries. In the lower middle income countries, it's only about 19%. Higher middle income countries, only 40%. But today we know that if you are able to offer this guideline-directed medical therapy to at least 2/3 of our patients, the outcome would be far, far better. The only difference in the thinking about heart failure management, because we were all thinking of conventionally putting them on an ACE, then an A beta blocker, then an MRA, SGL2. But the concept has slowly changed. There is a recent publication. Now we think of a rapid sequencing where you start adding beta blocker and SGL2 inhibitor. In fact, this is one of the big studies which got published, the Strong Heart of HF trial, where all these 1,778 patients, when they were started on all the 4 drugs, high intensity, within 2 weeks in the hospital, the usage of ARB increased from 2% to 55%, beta blocker from 4% to 45%, MRA also increased, and the primary outcome was remarkably different, 15.2% versus 23.3%. In fact, he said when the author of this paper is actually an anesthetist, Professor Alexandra Mebaza, I had an opportunity to talk with him. So he said he was getting a lot of phone calls. He was scared initially, thinking that these were killing more patients. But it was actually to congratulate him, saying that the rapid sequencing has actually led to remarkable improvement of the outcomes. So there's been a lot of other studies where they have looked at how this could be titrated. On day 1, you could have the SGLT2 inhibitor, MRA, beta blocker. So there are now various algorithms which are available. But it's very clear today from the hospitalization and the prevention of rehospitalization cardiovascular death, quicker titration suggests a greater reduction in events, as has been suggested. If you are able to put this all, the sequence 1A, the sequence below that you see there, 81.5% of them, the event probability comes down when you compare with the earlier sequencing. In fact, there have been a lot of other studies which have been coming. This is from 55 different countries. And the concept where I mentioned earlier, the first drug to be added is ARNI. This is slowly catching up in the western part of the country. But what is more important to understand is that this is the latest publication where the initiation titration target dose has been tried. The reluctance, despite all the data, what is interesting to see that dapagliflozin still not being utilized the way it should be. So I think a time has come for us to be using this drug in much higher number of patients. Again, the same thing about sacubitril valsartan, despite the level of evidence that we have this. This is what you see from the western country, evolution heart failure from UK. So I'm sure in a country like India, it's even more dismal. So I think this really calls for us to be a little more vigilant on our patients, have a checklist, and remember the new mantra, 4 drugs in 4 to 8 weeks, because this is really going to change the practice for heart failure in our country. And there's been a different thought, just got published yesterday. Diverting acute, just like you talk about the heart failure, the chest pain clinics, there's something called the short stay units for acute heart failure. I was mentioning earlier, somebody gets breathlessness, you just take a shot of Lasix in the emergency room and go off. Similarly, sicker patients are kept for a very short time in the ICU and sent. But then this outcome was not very different from the conventional way of treating patients. So this is not really caught up. We must also know that heart failure with preserved ejection fraction is an entity which is seen in about 15% of our registry data, slowly catching up. And today we know that the one drug which is really effective is SGLT2 inhibitor. I think so we cannot afford to lose out any patient on heart failure, this particularly important drug SGLT2 inhibitor. The ESC 2023 exactly the same for heart failure with preserved ejection fraction. But the important thing is, I'm just again trying to re-emphasize on heart failure reduced ejection fraction. When you have this patient, it is on the onus on the physician's part to follow these patients clinically over a period of 2 weeks, titrate the medicine, look at the heart rate and blood pressure, look at the renal function, electrolytes, the ventricular function once in about 3 to 6 months. If they are more frequent, if symptomatic and congestion is seen, routine echo to identify candidates for device therapy. And of course, the modern way of looking at it is by doing the NT-proBNP levels. There are newer gadgets to look at the peer pressure monitoring, which is becoming very popular in the western part of the country. But I think it's important to understand what you see on the bottom, I need help. This is, if your heart patients need an IV inotrope, they become class 3, class 4. They have a target organ damage like renal dysfunction. The ejection fraction, despite your therapy, it's going down. Getting frequent shocks, hospitalization, edema, low blood pressure, and that is the acronym, I need help. You need to really think one step further. And what is that? I think today, I'm sure with hospitals like Lizzie and many other centers, I'm sure a few centers in THRISSUR also will come up, where you will have access to the mechanical circulatory device. There are a lot of available devices in the country. At least some of them, the LV assist devices are very useful. The extracorporeal life system, ECMO, is becoming popular. Once Jayalalitha got it, I think people have started asking for it. Axial flow pump, many new things are coming up. And there is a tremendous benefit of this therapy. I think it's time that we realize this. Because we have seen that in patients who have bridged to transplant, the 6 minutes walk test, 94% of them could complete, whereas only initially it was 16%. So there is a definite improvement in the NYHA class 5 with this kind of therapy. This could either be a destination therapy or could be a bridge to transplant, and that is becoming very, very important. So the clinical evidence is, this is a study on 1,028 patients, 30 days outcome, 97% patients at 30-day high survival at 98%, 97% and 89% at 6 months. And the very slow stroke rate, 79%, 77% had an improved NYHA class 1, and the 6-minute walk test is a proof of the pudding. It is really phenomenal. So I think this is something which is available, at least in some part of the country. And when do you think about this? The ideal time for proposing this is NYHA class 3 or 4. Patient is not doing well, inability to walk 1 block, 1 or more heart failure hospitalizations, intolerant or refractory to the ACE or ARB or whatever drugs that we have mentioned. You have put them on a CRP like the lady has shown, they are not responding. Hematocrit less than 35%, serum sodium less than 136, blood urine nitrogen 40 milligram. So I think these become a suggestion for a mechanical circulatory device. So I'd like to end my talk here by saying that heart failure with reduced ejection fraction is a very serious and challenging problem. I've shown you the mortality. Over a period of 5 years, 50% of them, they die. So this is a really huge number. In a country with a prevalence of 1%, this is a very high figure, and I know the cardiologists alone cannot treat this condition. I think the need of the physicians should start engaging themselves in heart failure therapy. Guideline-directed medical therapy reduces mortality and improves quality of life, and it's important that you start all these 4 guideline-directed therapy at the earliest. Early initiation is a key. Don't wait for weeks or months. ARNI, the way to go about is start them as a first drug instead of an ACE or ARB. SGLT probably for all patients, because they have shown remarkable difference in outcomes. Follow-up is very crucial. It's not just shut it, forget it, when you forget about it. You need to follow them up 2 weeks, 4 weeks, 3 months. You must have your own patient data, because these are patients who need titration of medications. And please identify the poor responders, because you have some form of therapy for them. And I'm sure transplant is also slowly catching up. Newer therapy and interventions are really encouraging. So I think we need to hope to convert all the failure to smiles. Thank you all for the kind attention.
Equally common problem of heart failure with preserved ejection fraction. You gave only one slide to that. That's all right. Heart failure, because not much changes, but still lot of advances are happening in SGLT inhibitors, and ARNI are also being recommended for heart failure with preserved ejection fraction. We need to concentrate, because 50% of our patients with heart failure have preserved ejection fraction. Second point is, in patients with heart failure with improved ejection fraction, people you gave all the 4 drugs and then improved after 1 year, you do the ejection fraction even become normalized. In those patients, don't stop the 4 pillars. That is probably because people get recurrence once they stop the 4. You agree with that?
Absolutely.
And I also, thirdly, I think that medicine is an art and a science. But medicine is an art is exemplified in the management of heart failure, because it requires patience, your knowledge, and also a time spent with the patient, and also checking all the parameters. It is really an art if you want to bring in all the 4 drugs recommended for heart failure with reduced ejection fraction. I feel that general physicians are better equipped, because they have been titrating blood sugar. They have been titrating blood pressure. So they probably will be in a better position rather than cardiologists to titrate all these drugs, start with small dose and bring it up to the desired level. Thank you.
Thank you. I think that point is very well taken. Somebody has an improved ejection fraction, don't be carried away by the EF. Because the moment we have data, convincing evidence today, that if you go back, these patients are maybe stabilized with ACE, ARB, beta blockers, and SE, all the 4 drugs. When you start de-escalating and stopping these drugs, then they really go back to the previous state. They become again dilated cardiomyopathy. So I think you should not stop that. In fact, one of the reasons why I did not want to touch, because it's a very important area, preserved ejection fraction, I personally feel that this is probably underestimated in a country. All our registries, in fact, myself and Jabi, we just wrote up a review article on this. So it's close to about 15% in the Asian countries. But the point is, as a therapy, it's a disease of comorbidities. I think for a physician, it's managing the comorbidity, and just one drug, SGLT inhibitor. I didn't want to take too much time, because we still not got the therapy going in for heart failure, reduced ejection fraction, because this can be easily diagnosed.
Thank you, Jay Gopal. It was a real good talk covering from A to Z of heart failure with reduced ejection fraction. 20 or 25 years ago, if you go to any cardiac ICU, there will be 75% with acute coronary syndrome and 25% with heart failure. Now it has totally changed. I think in any ICU now 75 people are heart failure. Acute coronary syndrome has come. In fact, Braunwald said the only 2 cardiologists who are going to survive after 25 years are preventive cardiologists and heart failure specialists. Because as your treatment for acute coronary syndrome improves, as your treatment for diabetes improves, hypertension improves, chronic kidney disease improves, age becomes more elderly, finally all of them have to die, and the final common pathway is probably heart failure. So I think this is a big problem that all of us are going to face in the maybe next couple of decades.
Is there a cutoff value for the EGFR or serum creatinine above which you should not start the harming?
Yeah, but it's not, as of now, it's not recommended for patients with end-stage renal disease. That's an EGFR less than 15. But the patient is on dialysis, there is data, at least a very small, there is a study on about 100 plus patients, we have shown that patients on dialysis, you could still use it. But otherwise in EGFR less than 15 is a area where, SGL2 I think up to 20 we have data. ARNI, in fact, a nephrologist sitting here today, we are not really scared to put them. Only thing is they might need a close titration in terms of potassium and the creatinine values.